the challenge for us, and the challenge which will be presented in these cases, is the late presentation. And you know that commonly we have multiple opportunistic infections, that we have higher frequency of neurotoxoplasmosis and pneumocystinosis in our late cases, and that we have a huge number of hospital admissions for the late presenters. Okay, good. So now it started to work. The issue is that with late diagnosis, you have this huge mortality, especially in the first year of observation. So multiple patients die when they are being diagnosed late. And in these cases, I will show you two women above 50, so diagnosed not only late in the HIV stage, but also in the age, which is also affecting the frailty, which was also discussed today. And we see that quite commonly. So we see these female individuals who are over 50 to be diagnosed predominantly in AIDS condition. And we have made a small statistics just for our center. So it became very apparent that it's much more likely for you to have full diagnostics of cancer than a simple HIV test, which currently costs around 10 euros or less. So this is what is happening. If you are a female above 50, you will probably have a delayed HIV diagnosis, have all your cancer diagnosis, and then at the end somebody, especially, usually this will be a junior doctor who will do the HIV test, thinking that neutropenia it may be linked to HIV. So the first female, aged 63, was actually has a history of diseases which might have led to the diagnosis, and these which are typed in red, you could see this was hospital in hospital diagnostics over treatment. So there was at least this opportunity for HIV tests. So first cervical cancer, 2005, then myocardial infarction, 2011, then CABG, the same year, very short time after, bronchitis, oral candidiasis, also in the medical history. And then actually she was not diagnosed by herself. Her partner, 10 years younger partner, was diagnosed with HIV, so she was tested for HIV in 2012. Obviously, her CD4 count was well below 100, with huge viral load, more than 600,000 copies. This is regional, but we have subtype D. This is a white female, despite having this African virus. So this is our local spread. She has good tropism. She has good HLA, so she doesn't have HLA 5701. So abacavir would be an option if there was not a history of coronary artery disease. But she says, no, I do not accept this diagnosis. I do not want an HIV treatment. So she refuses CART. Not for long, for 6 months, because she comes in with severe dyspnea, and on normal chest X-ray, you have diagnosis of left-sided pneumothorax, which actually requires immediate thoracosurgical intervention. She is drained and improves, and then she is retained in a hospital for the further diagnostics and treatment. And at this time, she actually accepts the HIV diagnosis, but on CT scan of the lung, you have multiple issues there. So there are regions of ground glass, there are regions of small nodules in the lung. The summary of radiology is actually atypical inflammation. And at this time you would think either PCP or tuberculosis, wouldn't you? Okay, so to make your life a little bit more complicated, acid-phase bacilli returned positive. Actually, we didn't, and we have it now for 2 years, but in 2012, we didn't have RIF-TB PCR diagnostics available. It is in some countries available, in some is not, but then we didn't have it, so we had to wait for the identification for many weeks here, and her serum CMV DNA was 12,000 copies. So there is also likelihood that partially this ground glass, which you could see, may be due to CMV pneumonia. So decisions. Firstly, what do we have here as a summary from the HIV perspective and from the concomitant diseases perspective? So is it a pneumocystosis complicated by pneumothorax? Because you well remember that actually when you have pneumocystosis, the likelihood of pneumothorax, of bursting of partial of the lung, is much higher. It may be also true for the tuberculosis. She actually, on clinical examination of a fundus of the eye, has characteristic lesions for CMV retinitis, so this is confirmed. So certainly you have CMV retinitis, maybe you also have CMV pneumonia, oral candidiasis and wasting, probably due to all the concomitant diseases. You have history of coronary artery disease with non-ST elevation, myocardial infarction, and coronary artery bypass graft. You have arterial hypertension, cervical cancer in the history. There are also recurrent urinary tract infections, and her GFR is actually borderline to make our life more difficult. So the first clinical decisions: do we give the treatment to everything and wait if the patient survives? Do we actually select? So basically, this is what Saya would say, going on the yellow light or the red light. So we are driving usually sink or swim. So either the patient survives or not. There is not much to do. So she was considered to receive large doses, so PCP doses of Trimethoprim sulfamethoxazole. So we do 120 milligram dose per kilogram of a total. Rifampicin, isoniazid, ethambutol, pyrazinamide, also standard doses, 100 fluconazole, twice 250 ganciclovir, followed by valganciclovir, and then you have her 5 milligrams of ramipril, aspirin 150, bisoprolol 5 milligram, and consideration of megasterol for the wasting. So let's try and move from these drugs to the optimal card. So first, the key issue is the treatment of TB, because this is the first thing to look at. So the interaction between TB drugs and antiretroviral treatment. So we have selected the 4 classical drugs. And where do we go with antiretroviral? Actually, first let's look at the backbone. So you have TDF, you have TAF, you have lamivudine, other AZT we wouldn't give her. So please remember, and you know it very well by now, that TAF, which was not very well available in 2012, but still we could consider it for today, for the learning purposes for us. Please remember that TAF would not be the best option with rifampicin. Here you would have a decline of tenofovir concentration. So this option is basically gone. So you are left with abacavir, lamivudine, or tenofovir. Abacavir you wouldn't give in the setting of coronary artery disease. So this is gone as well. And then we have to think about integrase inhibitor or protease. So going back, most of the proteases are gone, and with rifampicin, you know that there is significant interaction. So we basically cannot give either protease inhibitor, or we would have to switch to rifabutin, which is not optimal either, because for us at least availability of rifabutin is poor. So it's a drug which requires a special ministry consent, so and it takes weeks to get it. So at least this option for us is limited. Obviously, non-nucleoside reverse transcriptase inhibitors like ripivirine, nevirapine are also out of question because of significant interaction, and all the cobicistat-based drugs are also gone. So basically we have only integrases, and you know well that also integrase inhibitors are subject to significant interaction, and this interaction first is with dolutegravir. Please note that most of us, what we do is increase the dose of dolutegravir to twice a day, 800 milligrams, so 2 pills twice a day. But look, there is still a significant issue. So even doubling the dose doesn't result in a full see-through concentration, optimal see-through concentration. On the other hand, dolutegravir is slightly better in this respect. If you double the dose of dolutegravir, you would get optimal concentrations, but only in people who do not have integrase inhibitor resistance. So if the integrase inhibitor resistance comes in, it becomes more difficult. Okay, so from this perspective, we would think TDF, FTC, plus dolutegravir or dolutegravir, which was not available at this time point. But we still have to think ganciclovir. What could happen with ganciclovir? And the lady has eGFR of 55. So there is a note of caution for both ganciclovir and emtricitabine tenofovir. Obviously, this is a nephrotoxic drug, and also I have included for you the co-administration with possible cobicistat, also note of caution. We wouldn't use it in this context, but I have included it as a word of caution. But ganciclovir is also potentially nephrotoxic. Here, trimethoprim sulfamethoxazole, there is an interaction with lamivudine, a little bit more orange, and then you have yellow-orange, so for the emtricitabine, so a little bit better. So again, point for emtricitabine, which we would have in tenofovir, disoproxin, and emtricitabine v. old Truvada co-formulation. And now the remaining issue, so we have this polypharmacized patient, and also she has her baseline drugs. So she has antiplatelate, she has bisoprolol, she has potentially megasterol, and she has ramipril. So we need to check for this. If we select integrase inhibitors, the co-infection, the interaction is, the potential for interaction is low. So we are on a safe side. So dolutegravir twice 800 plus TDF FTC. Probably you would select the same thing, maybe, yeah, if you have it available at the time point. So actually, the patient was hospitalized for 6 months, and this is just a brief history of what was happening. She has had Clostridium difficile colitis. So here you would give mostly vancomycin orally 4 times 250. So no interaction expected there, because it is virtually not absorbed from the GI tract. We have had E. coli sepsis, actually multiple ones. She needed to have vitrectomy because the retinitis was progressive, and obviously there was severe neutropenia with a combination of drugs which we have given her. You wouldn't expect anything else, basically. So G-CSF, filgrastim, was also administered intermittently, and as I have consulted, there is no interaction here expected with any of the antiretroviral drugs. To make our lives more difficult, this patient, please remember, doesn't accept the HIV diagnosis too much. So what she does, she's developing resistance to dolutegravir. So what we do, we begin to have available dolutegravir. So we put her on the double dose of dolutegravir. She's now off the antituberculotic drugs. But still, if she would be on antituberculotic drugs, and if she would have integrase resistance, we would be in a serious trouble, because if there was no rifabutin, you would have to change her to protease inhibitor. So this treatment would be extremely difficult. The viremia went down, but she didn't accept this treatment either, and dolutegravir in the end was not optimal. So we ended having this patient on darunavir, maraviroc, and dolutegravir BID. So quite a challenging regimen. The patient is suppressed until today, so she is well. And please remember that we could play a little bit with dolutegravir if we want to increase concentration, so we could play with the food addition. So this is what we counsel. We say, please take your dolutegravir with food. The patient answers, I don't like to eat. I do not have appetite. I do not want to eat too much. So what we do, we send the patient to the psychologist to diagnose for depression. And this is what you get. So you have full-fledged clinical depression. We also do the bone scan, and she has osteoporosis. eGFR is slightly lower. BMI is slightly better. So first we check for alendronic acid and ibandronic acid interaction with the regimen that we have. Fortunately, at least here, no problem, but depression treatment. And we have now, please remember, we have now darunavir boosted with ritonavir, we have dolutegravir, and we have maraviroc. So my favorite antidepressant is either venlafoxine or escitalopram or citalopram now. So we check for interactions. It's actually not bad, because what you have slight increase in escitalopram or citalopram concentration. So you just begin with the smallest dose, 5 milligrams. This is what we do, and we wait for the effect, and the effect is usually good. So this is what we did. We have started this patient on escitalopram, the lowest dose. She was a little bit better. Her mood improved. So this is the end of the story. Now her partner has erectile dysfunction, but we will not go into this for this case. This is not the case for drug-drug interactions. Here, this is about the late. So the second case, a little bit shorter because I have abridged it, and this lady was a little bit easier because we have had all the experience from the previous lady. So the previous lady was 2012, now we are in 2018, and look at the history again, and again this history is repeating itself. Ischemic stroke, no HIV test. Demyelinating, please help me with this word, I don't know how to pronounce it. It's a challenge. Anyway, a white lesion, decrease in the brain, you know what it is. I think only British people could pronounce the word. The diagnosis first done by the rheumatologist is SLE. I'm not rheumatological specialist, can't tell you why this lady was diagnosed with SLE, tried to link all the possible criteria and probable criteria, and I don't know how many she met. For me, I hope there are not many rheumatologists in the room. If you do not fulfill enough criteria, you are not diseased. Yeah? But anyway, she was fulfilling some of them. At least she has leukopenia, which was not rheumatoid disease, which was actually HIV. And she has erythematous facial lesions, which were supposed to be characteristic for lupus, which for me were classical HIV infected HIV infection associated lesions here. So then the rheumatologists followed the diagnosis. So she was diagnosed with antiphospholipid syndrome because she had cardiolipin antibodies 14, where the norm was 12. So a little bit of above the norm. And then actually she came to us with shingles, and we do HIV test in every shingle patient. We were actually thinking that this is a false negative ELISA, but it is actually quite high positive ELISA, because again, her CD found actually was exactly the same to the previous lady. No mutation at baseline, so she was put by the rheumatologist on vitamin K inhibitors plus aspirin and chloroquine. Please do not ask me why chloroquine. I can't answer that. She came with that as a treatment for antiphospholipid syndrome. Actually, during the in-hospital treatment, we have had a little bit of trouble because we have sent her on a standard ultrasound scan, and she ended up having significant bleeding into the muscles of abdomen because of pressure with an ultrasound machine. Then she was recovering. She needed to have it drained. She developed thrombosis in the right brachial artery because at this time after the bleeding, she didn't receive for a while any anticoagulants. So we ended having this trouble. And in the end, I must say I was quite happy with myself because I have ordered factor V assay, and she has Leiden mutation. So all the stroke issues and coagulation issues were not antiphospholipid, but were factor Leiden mutation, then coupled with severe HIV. So this is a little bit of more complex story, but not rheumatologic at all. Okay, so chloroquine interactions. Actually, in the end, we have withdrawn this chloroquine after consultations with rheumatologists, but we still needed to consider that for HIV treatment, potential QT prolongation with atazanavir or rilpivirine, but this is something which we had in mind, especially that this patient also has a history of stroke, so maybe there is also some cardiac problems coming in. Okay, so anticoagulant therapy as an issue. Sorry, but sorry for a little bit of a title that it's actually obstructing our view. Basically, all in green, you have all the nucleosides. Then you have combination, then you have non-nukes and protease inhibitors. What we would consider, she was on warfarin. We were considering on changing her to dabigatran or rivaroxaban. Clopidogrel we were also thinking about, but in the end she ended without clopidogrel, so no problem there. But please remember that there is a significant issue with dabigatran and cobicistat, so you have a significant increase of a dabigatran concentration, so the risk of bleeding is enormous. Also, clopidogrel actually has an issue because it is not working properly because there is insufficient platelet inhibition issue with boosted regimens. So please remember about it. And actually, anticoagulant issue was here the first line issue which we needed to deal with. In the end, also we have went for TDF, FTC, and dolutegravir. Okay, I'm into 4 minutes, but I'm basically done. Hope you enjoyed these two cases. This is like really riding in between of obstacles between baseline comorbidity, HIV-associated ones, and some diagnostics. We all have it. We all struggle, and this was just the example what we all do when you struggle with an HIV patient who is aging, who is more frail, where we only expect more trouble in the future. Thank you very much.